Again, thank you all for being here. My name is Eileen. I am the Outreach and Volunteer Coordinator here at NAMI Miami-Dade. And we are very excited for tonight's speaker meeting, the advancements of psychedelics research for the treatment of mental health conditions. We have Dr. Fisher here, who is going to give us so much information with his presentation tonight. So I'm going to go ahead and read Dr. Fisher's bio. So a former college basketball team captain, Joseph Scott Fisher graduated with a BA in economics from the University of Chicago in 2004 and worked for a year in options trading at the Chicago Board of Options Exchange before matriculating and subsequently graduating from the Feinberg School of Medicine at Northwestern University in 2009. His general psychiatry residency training was also done at Northwestern University before he completed his child and adolescent psychiatry fellowship at the University of Miami, Jackson Memorial Hospital. He developed expertise in the treatment of depression, anxiety, bipolar, and attention deficit disorders in his former private practice located in South Florida. In 2018, he completed the certificate in psychedelic therapy and research at the California Institute of Integral Studies, which including training in MDMA, psilocybin, LSD, and ketamine-assisted treatments. He takes an interest in research into psilocybin-facilitated and MDMA-facilitated psychotherapy as novel tools for treating depression, depressive anxiety, trauma-related, and eating disorders. He is board certified in adult psychiatry by the American Board of Psychiatry and Neurology. He is an integral member of Segal Trials Center for Psychedelic Research. Dr. Fisher has served as lead facilitator for over 30 dosing sessions on 3 separate studies of the psilocybin and LSD for treatment of depression and anxiety. In his free time, Dr. Fisher enjoys spending time with his family, friends, and dog, exploring nature, listening and playing music, cooking, traveling, and meeting new people. Such a great bio. So I want to introduce to you all Dr. Scott Fisher.
Thank you so much, Eileen.
You're welcome.
All right, really appreciate this opportunity to get to present on a topic that I have a lot of passion about, and really I'll do the presentation. I'll try and keep relatively brief to leave plenty of time for questions. It's often interesting to hear people's questions on the subject. So I'll just wait for Eileen to get the slides up. And
yes, give me 1 second.
Okay, perfect. Yeah, so I work at Segal Trials. We have a Center for Psychedelic Research. And I'm going to present today on psychedelic medicine, approaches to psychedelic-assisted therapy, clinical trials. Next slide, please. Okay, so you already heard some about my bio from Eileen, who very graciously agreed to read that out loud to you guys. So I think the important thing that I like to just emphasize is that I have worked in an outpatient practice we had a group practice in Broward and Palm Beach County. I did that for 8 years. So I'm pretty familiar with kind of the standard outpatient treatment. My practice consisted of, a lot of people diagnosed with depression, anxiety, substance use disorders, ADHD, PTSD, OCD, some bipolar disorder, and schizophrenia. But now I do work full-time at our Center for Psychedelic Research. My title is Lead Facilitator, Trainer, and Clinical Program Manager. So I really have, I think, a pretty good familiarity with kind of how treatment is being provided in our communities right now. And while I've seen, very many people have successes with, the medication management and the therapies and everything offered, I've also seen that there are many people who are not helped adequately enough with kind of our currently available therapeutics. That's kind of led me to be interested in what could help the people that aren't being helped with our current therapeutics. And I wanted to get involved in research, and psychedelics kind of represent a very different way of offering treatment compared to our currently available methods. Next slide, please. A little bit about Segal. So we're a site network here in Miami-Dade and Broward. We were one of the first sites in the US to work on psychedelics. We dosed the first patient in an LSD trial, I should say an FDA-registered LSD trial in over 40 years. We I also do a lot of other sort of mental health research, like in schizophrenia, bipolar, and other sorts of disorders. So psychedelics are a small sliver of what we do. We also have some women's health. Next slide, please. Our Center for Psychedelic Research, we're in Lauderhill. We're on Oakland Park Boulevard, not far from University Drive. And we have a whole team kind of dedicated to the psychedelic research. Like I said, the psychedelic treatments do seem to represent a big difference between the currently available medications and treatments. So you kind of need a team with specific expertise and a center that's really designed for the psychedelics, which we'll show you in a bit. Next slide, please. So this is just some more information about kind of our Psychedelic Research Center. You do need a special DEA Schedule I license to do this work because it's very restricted in terms of working with psychedelics. And so there's a lot of regulatory things we have to do to make this work. We have 3 dosing session rooms. We have facilitators like myself with an expertise in giving the psychological support and therapy. We also have a recruitment team. Next slide, please. So in terms of, clinical trials are different than, just going and getting treatment somewhere because we are doing a research study. And so we're really trying to determine if psychedelics can be safe and effective for the treatment of like a given disorder. So the way these studies work is generally you choose one substance, psychedelic compound or drug, for instance, let's say psilocybin, and you study if it's safe and effective to treat for a specific diagnosis or what the FDA calls an indication or disorder. So for instance, the first study we worked on was a study of psilocybin for major depressive disorder. Some key differences between the way psychedelic drugs are kind of given and used versus the way maybe a lot of other drugs are given and used nowadays, or medications, I should say, is that a lot of the medications being prescribed nowadays, you take on a daily basis or sometimes multiple times in a day, and you tend to stay on them over a long term of time. That isn't always the case, but that ends up what happening with a lot of people. The psychedelics are different. We are giving usually single or very few doses spaced out over longer periods of time. So it's not something that people are taking on a daily basis. Um, this is not like microdosing research. We're really looking at larger doses of psychedelics given in a very supportive context with a lot of preparation. If that could help, make like from that dosing experience, people in the weeks, months thereafter have their depression or their anxiety be cured. So most of the psychedelic research now is being done in things like depression, anxiety, PTSD, substance use disorders. We'll also have a study coming up in postpartum depression. There hasn't been a lot of work at this point in disorders like bipolar or schizophrenia. There are some signs that it could potentially, in some instances, make those disorders worse. So there's a lot of information we don't know about giving psychedelics in those sorts of problems, but there's some reason for caution there. And the way the studies tend to work is we have a very lengthy and in-depth screening assessment that happens to make sure that people seem to have, would be safe and healthy enough to continue forward in our studies, and also to make sure that they qualify. And then once that happens, they enter into more of the study process where we get a baseline kind of level your visit, and then we dose you and follow you over time. Now, the big difference also between this type of drug research and other sorts of medications are that we are very interested in what is the psychological and subjective experience that people have when they take a psychedelic. So we do preparation sessions with therapists with each of our study participants, where we really get to know them very well, understand their life history, understand what they're going through, understand what it is they're seeking treatment for. And we also get to give them information about the drug that they might be taking in the study, what its effects might be like, and how to navigate the altered state of consciousness that a psychedelic might kind of lead to. So these are pictures of our dosing rooms. So we will give the people the dose at our center in a room such as this, with usually two therapists are there with each participant. It's a very private, quiet environment. It's meant to be very kind of feel very safe and relaxing. That way, if people do kind of feel very different than their normal selves, they have a lot of support from the therapist there. And they also won't, have to find themselves in any sort of unsafe situation out in the community or with people who might not understand what it's like to take a psychedelic and kind of be in that altered state of consciousness. And we'll talk more about kind of some things that might happen with that altered state of consciousness. But to just round out the discussion about the study is, so once the psychedelic has worn off at the end of the day and people are kind of back to their normal state of mind, we'll send them home. And then we do meet with them in the weeks and months thereafter to see how they're doing, check in on them, check to see if their symptoms have changed or improved or not. Next slide, please. There's a picture of me in the dosing room. Next slide. Okay, so now some more information about psychedelics. Next slide. Okay, so psychedelics was coined by a psychiatrist, Dr. Osmond. Psychedelic means mind manifesting or mind revealing. He and the famous writer Aldous Huxley had a competition who could come up with a better word, and the psychiatrist beat the writer. Next slide, please. He made a little poem: to fathom hell or soar angelic, just take a pinch of psychedelic. Which really, we'll talk more about it, but psychedelics can really lead to just such an altered state of consciousness where you can feel, absolute bliss, euphoria on top of the world, or you can feel very paranoid, sad, afraid, as well. And sometimes all in the same experience, you can have that wide of a range. Next slide. Another term is entheogen, which means generating the divine within. Psychedelics, there's a lot of research being done onto kind of spirituality and mystical states that happen with psychedelics. Spirituality, religion, etc., are usually neglected by most of mainstream mental health kind of treatment providers and just the establishment in general. But we do find some research showing that people, if they have some spiritual or mystical experiences with their psychedelic dosing, may be able to improve more in depression, anxiety, things like that. So it could be that these types of experiences help moderate a beneficial outcome. That's definitely an area of active research. But I think the kind of spiritual side of psychedelics is definitely a big one of interest. Next slide. There's also a related term, empathogen, which is MDMA is kind of the best known empathogen. They're similar to psychedelics, but they don't tend to cause maybe as what we would think of as trippy effects to the same extent. They emphasize emotional relatedness, connectedness, love, and communion. They also reduce fear. They're being researched for PTSD. People are able to kind of explore their traumas with kind of reduced fear and able to process them in a way that maybe would be harder without kind of the benefit of the drug in their system. Next slide, please. Hallucinogen is kind of an outdated term because most psychedelics don't tend to cause true hallucinations, but more like illusions, closed-eye visuals, geometric patterns. Next slide. There are different types of kind of chemical backbones. As you can see, some of the psychedelics are related to things that occur naturally in the body, such as the top line there are phenethylamines, which are chemically related to dopamine. And in the bottom line there, we have tryptamines, which are chemically related to serotonin. So the psychedelic drugs interact with the receptors for these naturally occurring neurotransmitters or neurochemicals that occur in our brain. And we think that that's what's responsible for some of their effects. Next slide, please. So psilocybin is one of the ones being most actively researched. We have worked on, we're about to start our third study now of psilocybin. We have worked on psilocybin for major depressive disorder, and that's also the study we're about to start work on is of psilocybin for major depressive disorder. We also have a study of psilocybin for treatment-resistant depression. That is defined as people who have taken two antidepressants within their current episode of depression and haven't really gotten much help from those. Treatment-resistant depression, unfortunately, is pretty common. Psilocybin is also being researched for things like OCD, alcohol use disorder, eating disorders. It is the active ingredient of magic mushrooms, which you can see some pictures of there. The ancient Nahuatl word for psilocybin mushrooms was Teonanacatl, meaning flesh of the gods. So there's a long heritage and history of indigenous people of the Americas and certain areas of Mexico who have taken psilocybin containing mushrooms. And it's actually a lot of the psychedelic research is very heavily indebted to these indigenous people's use of the mushrooms, even despite they were prohibited by the Spanish when they colonized that area of the world. So the mushroom using people had to do so even under fear of penalty of death. So it really went underground, but has been maintained for hundreds of years and actually was reintroduced to kind of Western society by indigenous peoples there. Next slide, please. As you can see, those psilocybin mushrooms occur in over 100 different types of mushrooms or species of mushrooms, and they occur all over the world. So it seems likely that humans for a long time have likely been taking these mushrooms. Next slide, please. MDMA is being researched, as I mentioned, for post-traumatic stress disorder, PTSD. There's actually, the FDA is reviewing now whether they will approve MDMA for the treatment of PTSD. And should know by later this year if that will be approved. And they're very likely to approve it because the MDMA studies for PTSD really showed a big benefit with not too many safety risks associated with the MDMA. Next slide, please. Ayahuasca is another one people have heard of. It is an admixture brewed from two different plants in the Amazon basin. It has this DMT, dimethyltryptamine, which is chemically quite similar to psilocybin, or what your body processes psilocybin into. And that's thought to be the kind of active psychedelic that occurs in those green leaves that's there in the pot. But the body rapidly breaks down DMT unless you give it with something called an MAOI or MAO inhibitor, which is inhibits an enzyme in your body that breaks down the DMT. So somehow or another, the indigenous peoples of the Amazon discovered that if you combine the two plants, you're able to keep the DMT active and actually feel its effects. Whereas if you didn't combine the two plants, you wouldn't experience really any effects. Ayahuasca has also been a subject of a lot of research as well, and seems like it's likely to also have many of the same benefits that other psychedelics that I've talked about do as well. Next slide, please. So LSD, which is sometimes known by the street name of acid, was serendipitously discovered by Albert Hofmann, a Swiss chemist. LSD is derived from ergot, which is a type of fungus that occurs on rye. They'd actually kind of examined LSD sometime in the 30s, and they were unable to see if it had any, they I think tested it in animals, and they were looking to see if it could help with blood clotting, uterine bleeding, things like that, since they knew that ancient folk wisdom had said that ergot use could help with uterine bleeding. So they were trying to see if they could find a chemical in the ergot that might kind of help with that same problem and develop a drug out of it. Well, the animal testing didn't really show anything that interesting for them. So they put it up on the shelf. But a few years later, Hoffman had a hunch that that the LSD might actually have some interesting properties. So as he was working with it, he took it off the shelf and started working with it again. He accidentally dosed himself. And it's kind of a notorious folklore in LSD that, this, drug probably could have been easily looked over, but Hoffman's intuition led him to accidentally dose himself, and thereby he discovered the effects of LSD. LSD was very heavily researched before it became kind of used in the popular mainstream. it was very heavily researched in psychiatry for treatment of alcohol use disorder, neuroses, other things back in the 50s and 60s. But the Controlled Substance Act was passed in 1970 by Nixon and his administration. And it not only effectively banned all psychedelics and other sorts of drugs for the population's use, but also stopped all the research that had been so promising. So that research really it didn't happen for a good 30 or 40 years. And it's only in the last 20 or so years that doctors and scientists have started to research again whether these psychedelics could have some benefits. Next slide, please. Another important one to know about is mescaline, which is a drug that occurs in the peyote cactus and also the huachuma or San Pedro cactus. The peyote is there on the left. There are little buttons. That occurs in the southwest of the US and northern parts of Mexico. There is evidence showing that indigenous peoples in that part of the world have been using these for over 5,000 years. Um, it is actually part of the Native American church as well. They have special permission from the US government to use peyote as part of their religious practice, although it is illegal for anyone else to use the peyote. San Pedro occurs in the Andes. It's there on the right. Also a very beautiful ornamental cactus, and also has probably been used for a very long time by the indigenous peoples there. Next slide, please. So ketamine is one that is also worth mentioning. It isn't really a classical psychedelic per se. It was originally developed as a dissociative anesthetic and is actually used still a lot nowadays. That's its primary purpose still in medicine, would be for anesthesia. It also has pain-reducing features. It actually was used a lot in Vietnam as well, where it was known as the buddy drug because it just was, if somebody was hurt out in the field, they would often give them a big dose of ketamine, which would just kind of have them dissociate completely from kind of whatever injuries they were experiencing. It was invented and discovered by Calvin Stevens, a chemist here. It is now used in mental health, often for depression treatment and other sorts of PTSD, sometimes for anxiety, and it can cause altered states of consciousness, somewhat similar to the other psychedelics. And this one is already been FDA approved ever since 1970, as opposed to a lot of these other drugs that we're talking about are on the Schedule 1. They are not FDA approved. And that's why we're doing this research to see if they might actually have medical use and then become FDA approved and then come off of the DEA Schedule 1 to become available for some sort of prescription use. Next slide, please. And there's just so many more. There's hundreds of psychedelics that are out there. Here's just a few of them. But ibogaine is one definitely worth mentioning. That's being potentially researched for opiate use disorder that occurs in the iboga plant from West Africa and also has been used by peoples there for a very long time. So there's both naturally occurring psychedelics and also synthetic ones made in a lab. And so there's a wide range of where you can source your psychedelics from. Next slide, please. Psychedelics and mental health research. Okay, so we are looking for volunteers for psychedelics research studies. Right now, all of our studies are for depression. And we do have studies that will be starting for PTSD, post-traumatic stress disorder, and also postpartum depression as well. These are paid volunteer. All our study participants are paid for giving us their time and also for participating in this important research, as well as transportation. And yeah, we will also have a study for generalized anxiety disorders starting later in the year. Next slide, please. Okay, that's just some more information about referring yourself or someone else to us. Next slide, please. And here's some of our contact information. So just to circle back to kind of what we think is important is really examining what happens subjectively and psychologically during your psychedelic dosing sessions. So we do pay attention to if people have spiritual or mystical experiences where they feel connected, where they feel kind of a sense of knowledge being passed to them. There may also be some sort of religious experience, but that doesn't always happen. We also look at things like emotional breakthrough, where people feel like they have this kind of understanding of why their emotions have been affecting them the way that they do, or they feel that they're finally released from emotional patterns that had been um, plaguing them for so long, or they're finally able to fully feel emotions that they had been blocked in feeling, and then they kind of feel a relief after that. Another thing that can happen is psychological insight, where people will all of a sudden be able to connect the dots, like, oh, I, think like this because of something that happened in my upbringing, or something that's happening in my relationship right now, or this situation at work should be solved by such and such a way. Um, it should also be noted that there can be very challenging experiences, kind of as I alluded to earlier in the talk, where people can feel like really afraid, really sad, paranoid, scared, and sometimes can kind of lose touch with reality in a way that can be potentially harmful. So that's why we do our dosings at the center, to make sure if people do have challenging experiences, they are well supported and will be kept safe. In general, it's very uncommon for people, at least in our studies so far, to have challenging experiences. But it is something we definitely, tell everyone is a possibility that could happen. It is sometimes the case that if people are ready to have some challenging experiences, that actually can be an important part of their healing too. Sometimes we think some people's depression, anxiety, etc., might be an inability to fully face some very difficult situation or emotions in their life. And maybe the psychedelic dosing session is an opportunity for them to actually fully face that in a way that can be very challenging in the moment, but very relieving afterwards. So yeah, that's why we pay so much attention to the preparation, to making sure people are very well supported and safe during their dosing sessions, and also given a lot of support in the integration process thereafter. Um, yeah, so I think that about wraps it up for the presentation on my end, but I'd be really happy to field any questions that anyone attending might have for me.
If you do have any questions, you can put them in the chat or feel free to unmute yourself and ask your question.
Hello, this is Derek Fremd. Can
Hi,
you hear me?
Derek. Yes.
I got a couple of questions actually. If we take part in the trials, do we keep taking our normal meds that we've been taking through our psychiatrists, or do we have to not take those?
That's a great question. It really depends on which medications and which study. But let's say for our depression studies, most of the time it is necessary for people to come off of their antidepressants to be able to proceed in the dosing session. So that's something that it would be done under medical supervision. But even so, we understand that that can be challenging for some people. But it really is dependent on a number of other factors. But sometimes, yes, you do have to come off your drugs.
Okay, and you mentioned transportation. I'm guessing that we can't drive to and from our sessions there.
Well, you can for most of your sessions, but not for the drug dosing sessions, because when after people have taken a psychedelic, even though we think they're back down to the normal baseline, and likely it would be safe for them to drive, as a precaution, we make sure that either a friend is picking you up or a family member, or sometimes we're also to arrange transportation. But for all our visits, we're able to arrange transportation for people who maybe don't have a convenient mode of transport, or just prefer not to have to get themselves to the center. So that's done also for the convenience of our study participants.
And if I can take just one more minute of your time. I had very poor results with ketamine. Do you think that would kind of negate me as a participant in other trials?
That's a good question. We don't know. One of our studies, if someone has had a poor result with ketamine, then they're actually excluded from that study. But two of our other studies, they would still be allowed to proceed forward. So we don't know the answer to that question, but it might not necessarily exclude you from moving forward in one of our studies.
All right, thank you very much.
Thank you.
So we do have some questions in the chat, and I do see some hands raised, so I'm kind of going to go back and forth, okay? We have a question in this chat that says, how many preparation sessions occur?
Yeah,
And
so it depends on the
and how
study.
long are they?
Yeah, so usually there's at least 4 to 6 hours of preparation sessions, and those are done you in the days or weeks leading up to the dosing, in 1 to 3 separate sessions.
Okay, great. And then I see, so I'm going to start with some hands raised in that I can see. Thomas, if you want to unmute yourself and ask your question.
Hey, yeah. I have a background in harm reduction. I've seen people use psychedelics in very different ways in very different contexts. What can you comment on the power of expectation therapeutically when it comes to psychedelics? And what is your stance on blinded psychedelic trials, both in the current climate that we're in and in a hypothetic better environment in 15 years?
Yeah, I mean, I think that there's certainly a lot of people who think that expectation might shape, the psychedelic dosing in powerful ways. I don't they are starting to try to research if there is correlation between, kind of expectancy effects and outcomes. I don't think we have a good answer at this point. I have been, commonly often and pleasantly surprised that people's expectation is often very different than what happens in their dosing session. And for instance, we did a study of LSD for generalized anxiety, and many people were quite worried that their anxiety would be heightened during their LSD dosing, which certainly seemed possible to me as well. Anxiety can be a side effect of LSD and other psychedelics, and this is a population that is, primarily dealing with generalized anxiety, but it actually was very uncommon that people did experience high anxiety during their dosing sessions. So yeah, I think that is something that needs to be researched more, and whether that's something that could even be used therapeutically by helping shape people's expectancy to help kind of optimize their outcome is another area that I think might be researched. In terms of, blinding in these studies, any sort of study that is done, registered through the FDA, is generally a randomized, double-blind, placebo-controlled study. Now, that presents somewhat of an issue in psychedelics because most people can tell if they've taken an inactive placebo or if they've taken a high dose of a psychedelic. And very often people in the room, it's quite obvious by their behavior if it's altered and changed from their baseline, if it's different. So I think that it's, doing these kind of blinded studies right now are just kind of a necessary evil. I think it still does serve a purpose as having a control group. It's certainly not a perfectly blinded control group, but it's at least something of a control group and gives us some kind of barometer to measure from. Moving forward, I think as some of these get FDA approved, it'll be much more interesting to do research, not in these kind of placebo-controlled blinded studies, and do other sorts of research.
Thanks so much.
Thank you.
So next, I'm going to have Jonathan, if you want to unmute yourself and ask your question.
Hi, Dr. Scott. So in your experience, what do you see the role of other other disciplines that provide psychotherapy having in kind of the current psychedelic science movement? For example, psychiatrists are obviously able to prescribe controlled substances. However, other disciplines like social workers or licensed mental health counselors can't. But we do see how a lot of the knowledge we have on psychedelic therapy was done kind of by underground psychotherapists like Arnold Coleman and it from his book Psychedelic Psychotherapy. So how do you see people like LCSWs kind of fitting into this in the near future and also like 10 to 15 years from now?
Oh, I think that they'll be essential. You know, psychiatrists or other sorts of MDs will likely have to be on staff to prescribe. But the dosings, at least for the immediate future, we expect will happen at kind of a center. And they will happen with the guidance of therapists who could be psychiatrists, but could also be LCSW, psychologist, LMFT, you know, or even perhaps, you know, other sorts of licensed therapists. So I think that, you know, those sorts of therapists are going to be absolutely essential. Both, you know, in the research, many of our facilitators are LCSWs. I'm the only psychiatrist who's a facilitator, but also once, you know, if and when these are FDA approved, we're going to need a lot of manpower in terms of other sorts of credentialed therapists.
Thank you.
Yeah, thank you.
So I'm going to ask a question from the chat, and it says, are the sessions during standard business hours? What would qualify or disqualify a person from being in the trial?
So the sessions are our site is open Monday through Friday, 9 to 5. So those are when our sessions will happen at some point during kind of normal business hours. In terms of the qualifying criteria, so each study has its own individual criteria, and there are often in excess of 50 different criteria. So it's a little bit too numerous or lengthy to go through all of them. In general, if someone's interested in a psychedelic study and has the diagnosis that's being studied, for instance, if someone has been diagnosed with depression and is interested in a psychedelic study, then it would be good to reach out to us, because then what happens from there is we have one of our pre-screeners schedule either a brief on-site visit, or very often it's also done by telephone, where it's like a 20 to 30-minute assessment where we kind of get kind of the basics of someone's history. And from there, we start to have a good idea if they would qualify or not. So if you're interested, you know, it's too numerous to go through all the different criteria, but we could have a pre-screener do a brief assessment on the phone or in person and let you know if it would be worth going through the full screening visit. The full screening visit's usually a 4 to 5 hour visit on site with really kind of in-depth assessments, rating scales, lab draw, EKG, other sorts of kind of assessments as part of it. But the pre-screen would be kind of the main kind of way to answer if someone qualifies.
Great. And then I also have, is it qualitative data that you collect about it after and using assessment tools?
So there are plenty of studies that are getting qualitative data, but the FDA is really interested in it's still subjective data, but it is quantified in a certain way where we get might say if it's for depression, there's a depression rating scale that is administered to our study participant ahead of their dosing session, where they're asked kind of about their depression, and you know, they will rate, you know, on a scale of 1 to 10, you know, where is your depression? And so you get a score off of that. And then you do that same rating scale in the days and the weeks after the dosing session. And so the FDA is interested in what is the change in those rating scales from before the dosing to after.
Okay, and I have, how do you manage this type of intervention with people with substance abuse history, sorry?
Yeah, so the psychedelics themselves can certainly be abused in the sense of people taking them in unwise fashion, or people taking them to the detriment of their mental or emotional health. But most of them don't seem to be addictive. There are some exceptions to that. For instance, ketamine does seem to be addictive for some recreational users, but not addictive in the same sense that like alcohol or heroin could be physically addictive. There is some question as to whether the psychedelics could actually help substance use disorders. Now, we at our site have not yet had any studies start for substance use disorders. We were going to start one on an alcohol use disorder, but that one got delayed. So I think at this point, we don't know a whole lot of science about the answer to that question, but it does seem like some of the psychedelics given in this very kind of supportive context with a lot of oversight from the therapists and the team could potentially benefit from the psychedelics, but we really don't know if that's the case or if it could be unsafe for some people with substance use disorders to take some psychedelics. So it's a good question. I wish we knew the answer, but we don't.
Okay, and Francesca, if you want to unmute yourself so you can ask your question.
Yes, sure. Thank you. Hi again, Dr. Fisher.
Hi
I
there.
have a question. So a couple. First is, you mentioned there's some evidence that indicates for people with bipolar disorder or schizophrenia, it might actually be harmful. So I was wondering if you could just elaborate a bit on that and whether there's anything, any research with regards to people who are neurodivergent. And then just, I wanted to clarify the other pieces. What I understood you saying as far as projections into the future is that most likely as more research happens and as the FDA moves to approve some psychedelics, that they would likely get approved only under medical oversight, right? So is that, first of all, is that accurate? Like, and is your sense that specifically it would be required for people to use these medications with the support of therapists, right? Or some type of psychotherapy? And if, you know, if not, what are some of the broader political factors shaping how this might play out?
So, okay, so I'm going to answer the latter question because it's more recent in my mind. So the FDA is in the business of approving medications for medical use. In terms of a broader effort to legalize psychedelics, other sorts of drugs, that's something that would happen at a legislative level. In this case, the Controlled Substance Act would have to be either repealed or moderated or modified in very substantial ways to allow for legalization of psychedelics on a broader level. So the FDA is in the business of approving medications. Now, whether those are given with a therapist or not is up to the FDA, whether they administer it in a program where they specify, because most drugs don't have to be given with a therapist. Most drugs, once they're FDA approved, it's kind of up to a doctor to prescribe them however they think and see fit. But there are special programs that the FDA sometimes requires where they say, okay, if you're going to give, you know, if you're going to prescribe this drug, it has to be done with these circumstances. So the expectation is likely that if the FDA were to approve, say, MDMA for the treatment of post-traumatic stress disorder, that MDMA, when prescribed, would have to be given with the guidance of therapists at a center where people would be monitored and made sure that they're kept safe. What was your first question?
About the impact, the negative impacts on potentially on individuals with bipolar disorder and schizophrenia.
Yeah, so there's this is an area that needs research, and we really have a real lack of research in this area. But there's lots of case reports out there of people who have schizophrenia or bipolar disorder, their symptoms somehow getting worse after taking the psychedelics, which, you know, could potentially happen in other disorders as well. But because of the accumulation of these case reports, it's an area that so far there's been extreme caution. So, yeah, we definitely would like more information on that. But at this point, we don't have it. But there's some cause for concern.
Vanessa, if you want to unmute yourself.
Sure. Thank you, Dr. Fisher, for the presentation. I'm going to go a little bit along the lines what Jonathan was saying about people that are working either in clinical trials or in the future if we get this approved. So in the counseling therapists team, if you would be hiring people to work with you in the trial or in a clinic setup, what would you be looking for on the people working on your team?
Well, that's a good question. I think, you know, certainly we want someone who has some sort of background or expertise in working for psychedelics, and there are more and more programs becoming available for therapists to be able to study. For instance, the program that Eileen mentioned that I did at the California Institute of Integral Studies was a certificate of psychedelic therapy and research. The group MAPS, who has helped to sponsor the MDMA research, offers their training program. There's a university called Naropa out in Boulder, Colorado, that has a psychedelic certificate program. But at the end of the day, like, we're not totally sure of the answer to that because they haven't been FDA approved yet. So what is the FDA going to require? Almost certainly, you could probably have to do some training directly with the company that sponsored those drug research trials as well, at least at first, to be able to do that. So in the case of MAPS, they are offering that, and so people are able to do that in potential kind of anticipation and preparation for it to become FDA approved. But yeah, we're not totally sure. So yeah, I think some sort of previous training or background would be advantageous.
Thank you.
You're welcome.
So I'm going to ask a question from the chat that says, have been denied access to anxiety studies due to OCD. Will this continue to be the case? I don't want to hold out hope for a spot in the trial if there's no possibility.
So yeah, the way these studies tend to work is we choose a specific diagnosis or indication to study for that study. And then usually what would be excluded would be other major psychiatric diagnoses to enter also into that study. So although psilocybin has already shown some promise for OCD, and we're hoping that there'll be more and more clinical research into OCD, our particular site doesn't have an OCD study. So people with OCD would commonly, unfortunately, be excluded from that study, not because we have a belief that psychedelics don't help OCD, but because for the purposes of trying to keep a uniform population in that study, they exclude, say, for instance, if it's a study for generalized anxiety disorder, they don't also want to confound it with people who have OCD being in the study. So it's more of a science reason than a therapeutic reason. So hopefully at some point we will have an OCD study, but we don't quite yet.
Okay, well, let me ask you this then, if you don't mind. So then just having the OCD, even though I have it under control with medication, would just automatically eliminate me from any of the studies currently that you have right now, even though, you know,
I don't remember off the top of my head all the different criteria for all the different studies, unfortunately, but I think there's a high likelihood that any sort of, if the OCD is really kept in check, then, you know, there's a possibility, but it could be that for some of the studies that anyone that even is, like, we have to get medical records for a lot of our studies. So for instance, if OCD is on someone's medical record, it might be that the study sponsors require us to exclude them from the study. So unfortunately, that our hands are often tied in those cases.
Oh, okay. Yeah, I know you have to follow a certain criteria. I realize that, and you can't compromise your benefactors and your money stream, so to speak. And I understand that. I thought that if I had it under control and I could prove that I had it under control, that I would still be able to qualify for one of the studies. And I've just recently been diagnosed with PTSD as well. And so I was hoping that that would also be a factor. But if OCD is going to keep me out of the running, so to speak, then I'm not going to continue to throw my hat in the game, so to speak, and keep applying. I don't want to get my hopes up, even though my mental health counselor keeps telling me that I should keep applying. I'm not going to do so. So
yeah, it's unfortunately, you know, most people that apply will end up not qualifying for one of our studies because it does become so lengthy. But, you know, if you're up for, you know, giving it the effort and checking back every few months with us, like I mentioned, we do have a PTSD study starting. I don't know if OCD is excluded from that off the top of my head. But do feel free to reach out if you'd like. But I could understand the frustration in
yeah.
the no answer. So I apologize for that.
No, it's not your fault. I understand. I understand. Thank you, doctor. I appreciate it.
Thank you.
Alexandra, if you want to unmute yourself and ask your question.
Sure, thank you, Dr. Fish, a great presentation. Question for you: when you all provide the dosage during that session, to your knowledge, what are some of the interventions or some of the questions that are being asked of the person that is experiencing that at that point?
Yeah, that's a great question. So In general, we do spend a lot of time talking with our participants during the preparation and integration sessions. But during the dosing session, we actually have a musical playlist playing, and we encourage our participants to explore their dosing session introspectively. Now, we're there to talk if they want to talk, if they have questions, if they want to tell us what's happening, if they're experiencing difficulties that they need support with, then we are absolutely there to talk and give that sort of support. But we're not necessarily asking the people to talk during the session or any specific questions. It's a very non-directive approach. And we think that probably for many participants, the important thing is for them to experience what happens kind of in their mind during the dosing session, and only talk with us if they feel prompted to, but not necessarily to have to talk with us if what they're experiencing in their mind is kind of more salient material.
Excellent. Thank you.
Thank you.
So I'm going to see one of the questions from the chat. Someone asked, let me see, I'm trying to make sure there's no repeated question. So if you completed the pre-screening over a year ago, would we need to contact you again if we're a candidate at this time, or would they
Yes,
reach
yes,
out?
yes. We would definitely want to redo a pre-screen after a year to see if something has changed. So yeah, that would be good to reach back out.
And then another question that I have here is, how does integration work? How many sessions is it?
The integration, so usually we do an integration session the day after the dosing, a second one week after, and a third one 2 weeks after. So it's usually around 4 or 5 hours total of integration done over those 3 sessions in the weeks thereafter. Some people may require more support, after, and in that case, we try and help connect them with people who can provide continued sort of integration sort of services. But yeah, that's the standard for most of our studies.
And then I see some questions about medical history. You request medical records. Is there blood work involved before and after?
Yeah, so for a lot of our studies, we are asked to try and get the medical records, which sometimes can be hard to do because some doctors' offices aren't always easy to get a hold of for that. But most of our studies do want us to try and get those if people have previously been in any sort of psychiatric or medical treatment that might be pertinent to their study participation. And most of our studies will have blood work or lab draws done as part of the study.
Is there an upper age limit for the study?
It depends on the study. Some of our studies do have an upper age limit, somewhere in the 70s. Other of our studies don't have an upper age limit. So not necessarily.
Okay, and then do Segal trial pre-screeners have any further opportunities to shadow facilitators or receive training workshops?
That is sometimes a possibility for some of our pre-screeners, depending on their kind of credentials and background, to help out with some of the facilitation. But it often depends also on kind of what their role is in the pre-screening team, and a number of other factors. So I would say most of our pre-screeners don't get that opportunity, but there sometimes is that occasion where it can happen.
Okay, and then I have 2 final questions here. They said, what is the dose given? Is that determined just with the study within itself?
Yeah, so our studies tend to choose a specific dosage that they want to study to see if it's therapeutic. So it really depends on which study and kind of which compound that they're looking at. In general, we're looking to see if kind of a higher dose given in that supportive context can help kind of provide benefit for, say, depression. And lower doses aren't necessarily being studied to quite the same extent.
And then I know that you answered this in your presentation, but I do see some questions on it that may have been missed. Are the volunteers compensated?
Yes.
What is any extra said, I read here's a perk that they can receive? from participating?
Yeah, so people are it's a paid volunteer sort of opportunity, and I don't know that there's any other sort of extra perks aside from the monetary benefit given for study participation.
And then I have Alexandra may have her hand raised. I don't know if she still has a question, another question. If not, I have a final one here in the chat that says, do you think psychedelics can be helpful for neurodiverse people with autism or developmental disorders?
That's definitely been an area that's being studied now, in terms of different psychedelics to help with autistic symptoms. So we don't know the answer to that question yet, but it's probably being studied for a reason. So there's a chance that it could be useful.
Does anyone have any final questions before we end tonight's speaker meeting? It's been great. What seems to be all the questions. We want to thank you again so much, Dr. Fisher, for this informative and just speaking more on the research that you're doing. Again, I did put in some information about our helpline into the chat. We're getting a lot of thank yous in the chat as well, Dr. Fisher. So thank you everyone for joining us. And if you do have any further questions, you can reach out to us in regards to NAMI and our programs. And if not, you can ask us for the information for Segal Trials in case you weren't able to get it on the screen.
Yes, thank you so much for having me, and it was a real pleasure.
Of course.
Appreciate everyone that time.
Thank you, everyone. Have a great night.